That's a really good question. Kaleo is the group that really took the lead on forming that. So I can't speak for them, but I can speak to the importance and the timeliness of the collaborative, which is really that so many young kiddos now have food allergies, anaphylactic food allergies in particular. And so, because a lot of those kids can actually have their first reaction at an early child care center, we all really feel that we need to help early child care centers be prepared to first recognize and then be able to respond to an allergy emergency or anaphylaxis. So, check with Kaleo on why exactly they wanted to do it now, but I will tell you with the landscape of food allergy, I know that when I was a little girl, I knew one person who had a food allergy. And now it is multiple children that I know of, not just because I do food allergy, but being a mom, multiple kiddos have food allergies now in my kids' classes. And so helping these early childcare centers be prepared is just something we have to do. We're sort of behind the eight ball on it. So I'm so glad that Kaleo came to the table to align all these awesome partners to start getting this message out. That's a really good question. So that kind of comes back to why are we even really seeing food allergies? I say that, Job had a lot of bad stuff, but he didn't have a food allergy. And even allergies themselves really weren't like seasonal allergies really weren't first reported until like the 1800s. And then what we saw in fast forward to the 1900s, we started seeing some reports of peanut allergy, egg allergy, but then in the 1990s, we saw an uptick in peanut allergy. Based on that uptick, expert opinion said, oh, well, let's have kids avoid common allergens until their immune system is ready for it. Now, granted, this was expert opinion, not what we call now evidence-based medicine. Evidence-based medicine is when we have multiple studies demonstrating that one approach is superior to another approach. But so expert opinion was, well, let's have these babies avoid these allergens until their immune systems are ready. And that's why in the year 2000, the recommendation was to have babies avoid cow's milk until they're 1, avoid eggs until they're 2, and avoid peanuts, tree nuts, and shellfish until they're 3. And there wasn't good evidence for that. And then what we saw as a result of that delayed introduction of allergens is an even bigger increase in food allergy. And it wasn't really until around 2014 when what's called the LEAP study came out, learning early about peanut, that very clearly demonstrated that early introduction of allergens can significantly decrease the likelihood of babies, toddlers developing food allergy, specifically peanut allergy in the LEAP study. So we know that delaying the introduction of allergens can set a child up to developing the food allergy. But why in general, like why now are we having food allergies? We still have yet to understand that. Gap is the misunderstanding of what an allergic reaction can look like. A lot of people think that an anaphylactic or severe allergic reaction is going to have to involve trouble breathing, and it actually doesn't. There are a few definitions of anaphylaxis, probably the most comprehensive one being that a child or an adult ingest a food, and within a few minutes, typically 30 minutes, sometimes up to 2 hours, but really within the first 30 minutes, people are starting to have symptoms in the case of anaphylaxis from two systems. So that could be a child eats some peanut butter, a 13-month-old child eats peanut butter at childcare, had never had it before, or maybe had it before, tolerated it before, but this time, for whatever reason, eats it and then starts having hives and then vomits. Well, that's symptoms, itchy hives, rash, skin from two systems, the skin and the GI tract. So after exposure to an allergen, having two systems respond, that is anaphylaxis. It doesn't have to involve trouble breathing. And in addition to not having to involve trouble breathing, one of the other big gaps that I see is that early child care providers and even teachers, just laypersons in general, they also don't necessarily realize that a symptom of anaphylaxis can be a child suddenly not feeling well. So let's say a kiddo had just eaten lunch and then he's just suddenly not feeling well. He was playing around the schoolyard and now he just kind of wants to sit there and he's starting to curl up. That change in his mental status, that change in how he's feeling, that could actually be his first symptom of having an allergic reaction. Because then oftentimes what happens, especially in food allergies, the kiddo's not feeling well, and then the kiddo will start to vomit. And so a lot of kids, adults, a lot of people who are not well versed in food allergies and anaphylaxis don't realize that those two symptoms could be the child having a severe anaphylactic reaction. And if we don't promptly recognize and promptly treat that, then it allows things like trouble breathing, drop in blood pressure to then come on. Of course, an anaphylactic reaction can start by their first symptom being trouble breathing, but it doesn't have to include trouble breathing. It also doesn't have to include skin symptoms. So it's really important, and that's one reason I'm part of this collaborative, is it's really important that we provide early child care professionals with evidence-based, up-to-date information on what anaphylaxis looks like, how to prevent it, how to recognize it, and how to respond to it. So that's a really great question. And what you're getting at is really when can we use stock epinephrine? Stock epinephrine is epinephrine that is prescribed to an early child care center to be used in case of an emergency, in case a child with a known allergy doesn't have their device, their epinephrine autoinjector, or in case a child hasn't had a diagnosis yet, hasn't ingestion of an allergen, and then has symptoms. And what the symptoms that they're going to want to look for is really symptoms from those two systems that I mentioned. So you're looking for a pretty sudden onset within a few minutes, maybe 30 minutes, maybe an hour to two, but really it's pretty prompt when kids start feeling badly. And you're looking for symptoms from two systems. So that's going to be, you can have hives and vomiting. That can be you have vomiting and trouble breathing. That can be you have hives and trouble breathing. There's a few different combinations, but really you're looking for symptoms from two systems after ingestion of what could have been an allergen. It goes kind of back to my earlier concerns about what early child care professionals and laypersons in general and some healthcare providers might not even really realize. What we see, especially in the young kiddos in the beginning of the anaphylactic event, is their change in mental status. For the most part, kids want to run around and play. Like that's what they want to do. So if suddenly a child is running around and playing and then they're suddenly not feeling well, and then they're starting to have vomiting, hives, trouble breathing, then you're thinking, okay, this child is having an anaphylactic episode and you're going to want to treat with epinephrine. So it's really that change in mental status that I find can be missed sometimes. And then also thinking that, oh, well, you're only going to treat with epinephrine if you're having trouble breathing. That's absolutely not true. You want to treat with epinephrine as soon as you recognize that that person is having an anaphylactic event. And so hopefully it's never getting to having trouble breathing. And if epinephrine is administered promptly upon recognizing the anaphylactic reaction, many times, in most cases, we can prevent that scenario of there being trouble breathing and more severe symptoms. One of the easiest things that doctors can do is join the collaborative. It's free to join the collaborative. We'll get the website, but it's free to join the collaborative. And really what the collaborative does is it's brought together multiple stakeholders, multiple organizations who are truly dedicated to helping these children be safe, whether they're with their parents or whether they're in a child care center, whether they're at school, wherever they are. We want to help kids and adults be safer, those kids who have food allergies. So a physician can join the collaborative. They'll be given access to resources that can help them as physicians go out and train their local child care centers. Also, prescribing stock epinephrine can be such a blessing for centers. Different states have different regulations on how to do that. One of our partners, Code Anna, provides great information and guidance on how to navigate all that. But really the first step, the easiest step that a doc can do is just join the collaborative. And that way they're not wondering, okay, well, how do I even do this? The collaborative is going to help. Yeah, these types of collaboratives are huge when it comes to influencing policy, whether that's policy within early childcare centers, influencing policy on the landscape of legislative policy, because it shows that there are multiple stakeholders from multiple backgrounds that are saying with one unified voice that we need to help early childcare centers be prepared for allergy emergencies. And so that does help us gain momentum in expanding access to epinephrine, stock epinephrine in particular, making sure that all childcare centers across the country have access to stock epinephrine. I've heard multiple stories from multiple states of childcare professionals not having the medication. And also, when they don't have the medication, that means they also don't have the training to be able to prevent, recognize, and respond to the anaphylactic emergency. So, this type of collaborative gets everybody on the same page, unifies us all to, in one voice, say, we need to help prepare our early childcare centers.